Top Bed Talk.
It's my great pleasure to introduce Dr. David Yates. David is a consultant in anesthesia and intensive care at York. His research interests include prehab for high-risk surgical patients, the use of CPET for risk stratification, optimizing hemodynamics using non-invasive cardiac output monitoring, and improving perioperative outcomes using protocolized care. And he's recently set up one of the UK's first perioperative medicine services at York. Please join me in welcoming Dr. Yates.
Thank you very much for the introduction, and thank you for asking me to come and talk. I can't profess to be an academic expert in smoking cessation, but I am a jobbing clinician that gives out smoking cessation advice in my pre-assessment service, in the perioperative medicine service that we've set up. It's a focus in that, and we've set up the prehab service up in Middlesbrough with Jerry, and obviously it's a big part of that. So it's more of a practical overview of where we are in terms of perioperative smoking cessation. Smoking's bad for you, but you probably know that already. You definitely know that already. There is a smoking-related death every 4 seconds worldwide. So about a sixth of all worldwide deaths are due to smoking-related diseases. It leads to cancer, lung disease, heart disease. You know that. Primary care know that. Your patients know that. It's just fact, isn't it? We know it. We know smoking's bad. Smoking's bad in the perioperative period as well, and I know that you know this as well. Smoking results in increased lung complications, heart complications, bone healing problems, wound healing problems, stroke. You're 40% more likely to die after your major surgery if you are a smoker. So we know that smoking's bad for you in the perioperative period. Do patients know that it's bad for you in the perioperative period? And there's probably evidence out there that shows that they don't really know that smoking is bad in that perioperative period, in that short-term time when they could benefit from smoking cessation. So this is a survey of a couple of hundred patients who were asked, is smoking likely to cause any of the following? So slower healing of wounds, increased infection. So a third of patients didn't know that, only a third of patients knew that it was related to poor wound healing, increased risk of infections, etc., increased complications with the anaesthetic, compared to a much larger majority that were aware that it causes long-term harm. So I think my first point would be that there's a definite knowledge gap in terms of the patients that are coming under your care for major surgery. And that's the first thing we probably need to address. We also know intuitively that there are benefits of quitting. We've had multiple small studies, I'm not going to go into them in any detail, showing that if you stop smoking in the perioperative period, then you can improve post-operative outcomes. So there was a myth going around for a little while that if you stop smoking for a very short period of time before your major surgery, then it actually increased respiratory complications post-operatively. That all came from one small study in 1989 and a handful of cardiac patients. And in fact, there was no statistically significant difference in respiratory complications afterwards, but because there was a trend to increase complications, then that was reported widely as, you mustn't stop smoking in those 2 weeks before surgery. Because it increases risk. And I find trainees nowadays that are still hold that belief and still have been told that along the way. We have evidence now from short-term pre-op smoking cessation reviews that is not the case at all. And we must be telling patients to stop smoking at any stage in that run-up to surgery. Certainly the benefit from stopping smoking is seen from longer periods of abstinence before surgery. So the benefit, you do actually need to be stopped for longer periods, over 4 weeks ideally. But there's certainly no real risk in telling them to stop smoking at any stage. So getting them to stop smoking is good. How do you get them to stop smoking? Now, again, I'm no behaviour change expert, and there is a very nice paper, that top one, that's from a team in Leeds and Bradford, looking at different behaviour change techniques talking about how you encourage your patients to stop in the perioperative period. And there's a wide range of techniques that they look at and that the Cochrane Review looks at as well, and we'll have a brief run through those now. So what interventions have we got? We've got behavioural interventions, and those can range from the brief encounter that we'll talk about through to more intensive programmes of multi-session, multiple different types of behaviour change interventions, counselling, monitoring urinary nicotine, measuring exhaled carbon monoxide, all that kind of thing. We've got nicotine replacement therapy, we've got varenicline or Champix, and then I thought I'd just briefly mention e-cigs and vaping at the end as well. Now, then, brief encounters. Now, I think every smoking cessation organisation or body throughout the world has got some form of brief encounter format that they'd like all healthcare providers to do with their patients whenever they see them. Again, this is about making every encounter count. And this one's from Denmark, I think, this sort of idea of ask, advise, act. So ask and record smoking status, advise patients of the personal health benefits of quitting, and that's where this whole perioperative teachable moment comes in, because patients don't necessarily know that it does benefit them in the short term if they can stop smoking. And then act, and this is about providing more information, referring them to the local smoking cessation services, monitoring for withdrawal symptoms, etc., etc. So we should be doing this every time we meet a patient. So you're all enthusiasts, so we'll have a quick show of hands. Who reliably does this every time they see a patient in the perioperative setting? So we've got a few, that's pretty good, but it's by no means all, is it? And I think we can all accept that we're probably guilty of maybe falling down on this. And that's in the literature as well. There's been a study of survey of American anaesthetists and surgeons asking them, do you do this with your patients? 90% said, yes, we definitely ask whether they smoke. Well, that's just part of a medical history, isn't it? We should be asking every patient. 30% of anaesthetists and 60% of surgeons said that I advise my patients to then stop smoking, having established that they do smoke. And 5% of anaesthetists and 23% of surgeons actually say, I go that one step further and signpost them onto the relevant services. So you are not alone. We are not good at actually taking the opportunity to get our patients to stop smoking. Moving on, bit of nicotine replacement therapy. So this is really the sort of the mainstay, I suppose, of a lot of smoking cessation, a crucial part of a lot of smoking cessation programs. And the idea, obviously, is to prevent those withdrawal symptoms that you get from stopping smoking. It comes in a whole range of gum, inhalers, patches, obviously. And probably around the perioperative setting, the most effective way of working out what to give, and certainly what we've started using in York in our perioperative setting, is the Fagerstrom score. So the idea here is there's good evidence for this in the perioperative setting. A series of questions along the lines of, how soon after waking up do you have your first cigarette? If you're in bed ill all day, do you still smoke? That kind of thing. And obviously the score that you rack up dictates how much nicotine you're going to need, what sort of dosage you're going to need. So as I say, this is part of the mainstay of an awful lot of those smoking cessation programs around. Moving on to Champix or varenicline. The idea of this is a nicotinic alpha-4 beta-2 receptor partial agonist. So it ends up binding and providing that sort of low-level stimulation to prevent the withdrawal symptoms, but also blocking the receptors so that when you smoke, you don't have that nicotine rush caused by the dopamine release that you get from the activation of these receptors. And there's certainly good evidence in the non-surgical population that it works and it's effective. The idea is that you take a 12-week course that starts 2 weeks before your planned smoking cessation date. So again, we need to think about this. If we're going to use this in the perioperative setting, we need to think about how far before we want to actually start this. Because if we want a decent period of abstinence, we need to run up to increase the dosing of the Champix before you then stop. Ideally, we need to be starting this, at least 6 weeks before the surgical date if we can. There is emerging evidence in the pre-op population that this is effective. And I think it certainly is worth thinking about. And if you have patients who are struggling to stop smoking, then this is obviously a useful thing to be using. There have been concerns about neuropsychiatric side effects and depression and things like that, which don't seem to be borne out with the longer use and the longer it's been available. Certainly nausea and headaches are probably the main side effects of this. I thought I'd briefly touch on vaping. So it's topical at the moment, isn't it? We've gone from cigar-likes in the top left there through to vape pens and other vaping systems, through to these things which have mods. Apparently, they're called mods. You can dial up your dose of nicotine that you want and get your fix that way. And obviously, the idea of these is that you're getting nicotine, and so you're getting the hit. And you're feeding the addiction, but you're not getting the 3,000 carcinogens that you've got in one cigarette. So there's no doubt that they're better for you in terms of cancer and etc. But it is topical at the minute, isn't it? And they've just been banned in San Francisco, just a quick screenshot from last week, because we don't know what the long-term impact of vaping is. And also there is concern that it's getting children into smoking as well, and starting with vaping. I think the message at the moment would be that vaping's okay. Vaping's better than smoking. So if you can stop them smoking, if they want to vape around the time of surgery, that's fine, let them vape. So we've got a whole suite of fairly easy to deliver and effective interventions that we can use. What about the attitudes? Now, you saw this paper presented yesterday by Suzanne looking at behaviour change before surgery. And patients were asked whether you'd be willing to stop smoking for that short-term gain of reducing complications after your surgery versus stopping smoking for long-term, reducing cancer risk, lung disease, etc., etc. And there was a difference in terms of patients being more willing to stop smoking, having more motivation to stop smoking for shorter-term gain than long-term gain. But what was most striking is the confidence scores of being able to stop smoking in the perioperative period. And the confidence scores were much lower than the motivation scores. And the confidence to stop smoking was much lower than the confidence to be able to exercise more, to give up booze if they need to, all that kind of thing. So this is a real problem, that we've got motivation to quit, but lack of confidence to do so. The hardening hypothesis. I don't know whether you've heard of this. This is about these sort of hardened smokers that know smoking's bad for you. We all know it's bad for you, but we're still going to smoke. They never try and quit. They don't engage with the smoking cessation services at all. But the perioperative setting might be an opportunity there as well. This is a review of patients in the oncology population, so diagnosed with cancer, and offered smoking cessation interventions. And the first line of the discussion states that a statistically significant difference was not demonstrated between cessation interventions and usual care in the oncology population, except in the perioperative period. So these hardened smokers, you've got a cancer, they're still going to carry on smoking, you need a big operation, there's your opportunity to step in and stop them. So we've got a bit of a perfect storm, haven't we? We've got patients that don't know they should stop before their operation. We've got patients that are willing to stop for short-term gain, but so the teachable moment is real. But even motivated patients have low confidence that they can stop. We've got healthcare professionals that feel that they should tell patients to stop, but we're not telling them to stop reliably, despite having ready access to good evidence-based treatments that are relatively easy to deliver. And what we haven't mentioned is that we've got this enforced cessation period whilst patients are in hospital. So apart from enhanced recovery that gets them up and about straight away and they go and mobilise. So it's not really a perfect storm, is it? It's probably a perfect opportunity, and I think I would suggest that we need to do better in our approach to smoking in the perioperative setting. Thank you very much.
Top Med Talk. Thanks for downloading Top Med Talk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, Top Med Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.